Okay, so now that it's 7:34, we'll get started. We're going to run through three main topics today: antimicrobial resistance, parasites, and drugs used for infections. First of all, antimicrobial resistance and resistance transfer. So in this topic, we're going to talk about what antibiotic resistance means. And this means when you give someone antibiotics and it doesn't work to fight against their infection, how this happens, how bacteria or how microbes are able to fight against antimicrobial agents, what are the risk factors for this huge problem that is happening globally, and how we can take actions to fight against antibiotic resistance. So antimicrobial resistance is essentially when something is unresponsive to antimicrobial treatment, and it includes bactericidal, fungicidal, virucidal, or parasiticidal effects of a chemotherapeutic agent. So there are 5 major targets of antibiotics, and you will need to know them. You'll need to know them because later when May talks about the drugs, and by the end of this week, you should have a general gist of what the main kind of drugs do and what they target. For example, if this is a bacteria and you've got cell wall here, so we know that there's a class of antimicrobials, beta-lactams, and they include penicillins and cephalosporins, and they target the cell wall properties of bacteria. So cell wall, some target plasma membrane, some target ribosomes through 30S and 50S, some target metabolic pathways, and some target DNA and RNA synthesis. The mechanisms of resistance to antibiotics include 4 things. So 1, innate, means that some microbials, some bacteria, naturally have resistance to antibiotics. That may be because of its structure, which we'll talk about. The second one is alters the target site. So some bacteria are able to gain this sort of function, they unlock this function to be able to change the target site of antibiotics so that antibiotics cannot come in. Others change the access to target sites. So some antibiotics may reach the microbe, but they can't go in as high numbers. And some microbes have the ability to destroy antibiotics. Innate resistance to antibiotics. So 2 examples that you'll need to know would be gram-negative bacteria, some of them, and mycobacteria. So mycobacteria can fight against antibiotics because they have this layer of mycolic acids here. And gram-negative bacteria can fight against antibiotics because it has an outer membrane to protect it. Not all gram-negative, but that's just some examples. And if you don't have natural, sorry about the noise. If you don't have natural innate resistance, then you have to acquire antibiotic resistance. And so that comes in 3 ways, either via transformation, conjugation, or transduction. Transformation means that you've got this plasmid, which is circular DNA, coming into the cell, and then it is part of it now. Conjugation is a little bit different. It involves the sharing of a plasmid between 2 cells. So here we've got something called a sex pilus. And so you've got 2 cells. One of them has the plasmid and inside this plasmid would be qualities to fight against antibiotics. And so what happens is you've got a tube, or the sex pilus extends between 2 cells, and then the plasmid would be able to replicate and then travel across this tube. And so now 2 cells have this quality to fight against antibiotics. And the third one is transduction. It's where cells can gain DNA, not from a pilus or from plasmids just entering, but because DNA, a virus will inject that DNA into a cell. And then what happens is that DNA is chopped up, and then inserted into the DNA of the host. You'll need to just understand have a general gist of this. If it is difficult for you to differentiate between the three, or you're not really understanding, in the speaker notes, I've attached a link to a Khan Academy article. And this is also where I got these diagrams from. And it's pretty good too. It's a little bit more detailed than the lecture notes, so that might help. Next, we're going to move to examples of mechanisms of antibiotic resistance. So as I was mentioning before, if you don't have natural qualities to fight against antibiotics, then you can gain qualities via conjugation and transduction and stuff like that. So first, if you look here, you've got a modified cell wall protein. So one way would be that antibiotic can't even go into the cell in the first place. It bounces right off the new kind of wall. Sometimes it might reach, but then it can't go in high numbers because of the target. Or sometimes it might go into the cell, but there's an enzyme that inactivates the medicine that you've taken, so it doesn't work anymore. And sometimes you've got properties where antibiotic molecules can go into the cell, but there's an efflux pump that pumps it all out. So there's essentially no point if you're going to take these medications, but the medication isn't going to actually get to the target site. Plasmids. So plasmids are the circular DNA molecule we were looking at, and they can be transferred between bacterial cells via conjugation. So the plasmids we're going to focus on in particular are resistance plasmids, also known as R plasmids, and they move a copy of the plasmid from one bacteria to another bacteria. And so now both cells have antibiotic resistance. And they have a lot of functions you can see here. Essentially, they carry the functions that can make a cell be resistant to any antibiotics. Transposons are a little bit different. They're also known as jumping genes, and so they jump from one place to another. Here, they are jumping from the chromosome, the pink bit in particular. So they're jumping from the chromosome into a plasmid, and because it's able to jump into a plasmid, this plasmid will be inserted into other cells. Through the mechanisms of transposons, really increase the risk of antimicrobial resistance, because genes can spread really quickly, especially through huge populations. Antibiotic use and antibiotic resistance. So now we need to understand how antibiotic resistance is a problem and how it happens in the first place. So it's the evolution and spread of antibiotic resistance. And the reason why it happens is because there are selective pressures that are associated with antibiotic use. What this means is if you have, for example, an agar plate and it's got cultures in it, and you've got different colonies of bacteria, and this agar plate is supposed to mimic the conditions inside your body. But if you have antibiotics, it will destroy some of the colonies of bacteria inside your agar plate, but some of them will remain behind, because the ones that remain behind are the ones that are resistant to the antibiotics that you've taken. So now what happens is the antibiotics has solved a short-term problem, which is removed some of the bacteria in the colonies, but the ones that are left behind, the ones that are resistant and the ones that are much more powerful, now have a lot more resources to divide. And now they take up a larger proportion of the plate. So what this means is antibiotic use is a main reason why bacteria are becoming resistant to antibiotics. Additional factors include the fact that binary fission, which is the process where bacteria divide, happens really quickly. And because division happens so quickly, there's also a high rate of mutations. And that also means that we're going to have a higher chance of genes being altered to get this resistance. You've also got the use of plasmids and transposons, which we talked about, which increase the rate of antibiotic resistance spreading, as well as the fact that we use it outside of medicine too. So we have doctors prescribing it every day, but then farmers giving it to livestock every day and vets giving it to domesticated animals as well. So it's being given to not only just people. And sometimes in practice, we have people who can't afford antibiotics, although they can't afford to buy the full course. So they just have an infection, but then they only take antibiotics for half of the time they're supposed to take it for. That means that without taking the full course of antibiotics, you can't eradicate your entire infection, which leads you to only destroy the weak bacteria, but leaving the strong ones. Sometimes sometimes doctors may prescribe antibiotics when it's not necessary. Sometimes patients demand antibiotics even if they have a viral infection, which we know won't work. And so these are some of the ways antibiotic resistance rises. There's a diagram like this in the lecture notes as well, but this one looks a bit prettier, so I put this one in. This shows you the ways that we're spreading antibiotic resistance. So you've got through livestock, and then when farmers feed animals antibiotics, this antibiotics is spreading through waterways, through the crops, through the feces of these animals, and then humans are coming into contact with the soil or the water or the food, as well as the fact that people in hospitals are more likely to have antibiotic resistance as well. And then when they go home from hospital, they can spread it to the community. Some examples of bacteria that are really resistant that weren't before, so this means it's not innate, but it's an adaptive quality, is MRSA, methicillin-resistant Staphylococcus aureus. It's commonly acquired in the hospital, and for this we say they are nosocomial infections. Vancomycin is often the only drug that will fight against MRSA, and MRSA is really easily transmissible. But the problem is now we have MRSA that's vancomycin resistant too. So now we call it VRSA, vancomycin resistant Staphylococcus aureus. So that's worse. We also have gram-negative bacteria. So sometimes this drug, carbapenems, are the last resort for gram-negative bacteria, but now there's a rise of gut bacteria that is carbapenem resistant. And these are two examples of things that we need to look out for, and two examples of the rise of antibiotic resistance. So what can we do to address antibiotic resistance? This is something you can read as you can just read the slide. I won't have to read it out for you, but essentially for doctors, it would be to improve how we prescribe it by prescribing prescribing antibiotics with a narrow spectrum, meaning there are some antibiotics that have a wide spectrum, so they can target lots of bacteria. But we want to be prescribing with the narrowest spectrum possible. So that means if you know what the causative agent is, you prescribe the antibiotic that is targeting that causative agent rather than prescribing something with a wide spectrum, and only prescribing them for bacterial infections. You can also have scientists and researchers track resistance patterns, meaning that they continually test and track which bacteria are becoming resistant to antibiotics. And then for developers, also to develop new antibiotics. For the public, it's to prevent infections, to prevent the spread, to practice proper hand hygiene, public education of hand hygiene and infection prevention, and vaccination.
Okay, so I'll just talk a bit about parasites. So do you want to go to the next slide, Caroline? So the first thing is that there's a lot to remember in terms of parasites, and I guess with most of your microbial infections. I think I'll just before I go into each infection, because there's a lot of detail for each one, I think when you're actually studying it, it's probably more useful to group together some of the things that you'll see are very reoccurring. So one of the examples is that a lot of the infections can be diagnosed by the microscopy of stools. So it's just easier if you make a list of the infections that are diagnosed in that way, and then similarly for other things that are really reoccurring a lot, do the similar thing. And another thing is when you're learning the symptoms, I think try to focus on the ones that distinguish an infection from other ones. So don't really focus on, I guess, diarrhea, because a lot of parasitic infections will cause diarrhea, but you would want to focus on something very specific, like in Giardia, you have greasy, foul-smelling stools for that infection, and also focusing on the body site that is being specifically infected will help, because that can give you a lot of clues as to what symptoms you're going to see. With that first dot point where I mentioned on symptoms, that's going to really help you in, say, exams, where they will usually mention a key defining feature of an infection. So it's easy if you know and can identify that. And then when you're learning the pharmacological treatments, I think the easiest way is probably just to kind of separate medications on its own and kind of treat it as its own like farm lecture, because there are a lot of drugs that you can use for a variety of infections. So kind of like what I said in the first point, because it's so reoccurring, you can probably memorize or remember certain drugs can treat a variety of infections, and that'll make it easier. Okay, so I'll talk about the first infection. No, I won't. So I'll talk about the classifications of parasites. So a parasite in definition is just an organism that benefits from deriving nutrients at the expense of the host. And there are two types of parasites, but obviously we'll focus on the ones that live inside your body, which are endoparasites. So there's two key types. There's protozoa and there's helminths. So protozoa are unicellular eukaryotes, and then helminths are multicellular. They're just like worms. And so in protozoa, you have the four key ones that you need to know are malaria, Trichomonas vaginalis, Giardia, and Toxoplasma gondii. And then with your helminths, you need to know your roundworms and your flatworms. Also know that, just know the alternative words. So nematodes and roundworms mean the same thing. And then under roundworms, you have pinworms, hookworms, and filariasis. And then under flatworms, you have tapeworms and flukes. Okay, so malaria, this disease is caused by the Plasmodium species. So there's 5 different bacteria that will, not bacteria, parasites that will cause it. But the main one that you need to know is the Plasmodium falciparum, and that one is the most severe one. So that's the one that will cause a high number of parasites in your blood, and that's the one that will cause the most damage as well. In terms of the symptoms, so malaria is going to infect your blood and your central nervous system. So you will get fever-like symptoms, but you'll also get things like severe anemia. And a very key important thing to note is that fever in a return traveler is malaria until proven otherwise, and that you might see repeatedly coming up because that's just an important thing to know. In terms of the diagnosis, so the key one is microscopy of blood samples because malaria is infecting your blood. And then you can also do things like PCR and rapid diagnostic tests, as with most things. And then in terms of the treatment, you usually use combination therapies, and that can be used for both treating and prophylaxis, so preventing someone from being infected by malaria. So that will play into prevention. So if you have someone traveling to an area where they're likely to get malaria, you can give them a combination prophylactic treatment. And then other things like just preventing being bitten by mosquitoes, pretty much. In terms of the life cycle of malaria, it's not very important to know the details, but I think a key step was the fact that the clinical symptoms that you see are going to start after that step that the arrow is pointing to. So that's when, after the red blood cells rupture, and they will release parasites into your circulation, and that's when you start to see the things like anemia and fever. Your next parasite is trichomoniasis, and that's caused by Trichomonas vaginalis. So this one, important to note that it's an STI, and that can obviously help you remember a lot of the symptoms. So it mainly affects people with vaginas, and it's largely asymptomatic in people without. So about 70% of people who are infected with this parasite don't show any symptoms or signs. But if you do show symptoms, the key one to remember is smelly, frothy vaginal discharge. And then you can also have things like cervical ulcers, abdominal comfort, dysuria, and dyspareunia. And then you're also going to be predisposed to other STDs. So when you're treating them, you want to scan for potentially if they have other STDs. In terms of the diagnosis, again, you're going to do microscopy. So in women, you would use the vaginal fluid, but in men, you would use urine. You can also use a pap smear and, again, the rapid antigen or PCR tests. And then the treatment is metronidazole. Metronidazole is one of those antibacterials that will pop up a lot. So I guess this is one of those ones that you want to take aside and maybe make a list of the infections that you can treat with it. Okay, so then there's toxoplasmosis, which is caused by Toxoplasma gondii. So in terms of the transmission, you would get it from ingesting any raw undercooked meat that has cysts of this parasite. A key one, and I think in a lot of exam questions, they will tend to focus on the cat feces, so any contamination of cat feces. So that should just ring bells for Toxoplasma gondii. So that could be in the litter tray, gardening, anywhere where they could be. And then there's contaminated food or drinking water. Another key one is transplacental. So if a mother is infected, it could potentially spread to the fetus. And that can have pretty big consequences, which I will talk about in a bit. In terms of the diagnosis, the key ones are serology, histology, and radiology. And if a mother who is pregnant happens to be infected, you can also do a PCR test of the amniotic fluid, and that can give a suggestion as to whether the fetus has also been exposed to the parasite. And then in terms of treatment, you would use these two drugs there, pyrimethamine and sulfadiazine. And then the symptoms and complications. So Toxoplasma gondii will infect your central nervous system and your lymph nodes. So it will affect a healthy individual different to how it will affect a pregnant or immunosuppressed individual. So if you're healthy, you can the cysts will form, and the symptoms that you experience are going to depend on where the cysts are. So they could be quite serious symptoms, or they could affect you quite a lot if those cysts are in your eye or your brain. So you could get things like an acute systemic inflammatory response, flu-like symptoms, and if it invades your GIT, you can get some GIT issues. But it's a bit more serious if you're pregnant or immunosuppressed, because if you're pregnant, for example, it could lead to a lot of fetal abnormalities, things like eye and brain damage. And the where those cysts form, so in your gut or your eye, heart, brain, the complications that you get are just going to be more severe. Also, another thing to note is that it can you can get a reactivation of the cyst after many years. So when you get it, you might be healthy, but then maybe later down the track in your life, if you're pregnant or you become immunosuppressed, those cysts can reactivate and you will be reinfected. Okay, so with giardiasis, it's caused by those three parasites there. They are all actually the same parasite. There's just three different names for the same thing. But just be familiar with those because any of them can pop up. In terms of the transmission, so the cysts are going to be in contaminated water sources, and a trophozoite, which is just a protozoa that's in the active feeding stage of the life cycle. They will multiply and colonize the small intestine, and then the cysts will shed in your feces. So because this parasite mainly infects your upper GIT, a big feature is the prevention of nutrient absorption. So because you can't absorb those things like fats in your food, you end up with first watery, but then you end up developing greasy and foul smelling stools because you have more fat in there and lipids. And then because it's of the GIT, you get typical abdominal pain, nausea, bloating, flatulence. And then in terms of the diagnosis, it's another one where you can detect parts of it like cysts or trophozoites in the microscopy of the stool. And then the treatment again is metronidazole and can also be tonidazole, which is a very similar drug, but I think the drug of choice is metronidazole. And then in terms of prevention, just pretty much good hygiene and not having anything that's contaminated. So now in terms of helminths or parasitic worms, there are two big categories, so roundworms and flatworms, and then I'll talk about each one underneath there. So the first one is hookworms. So the symptoms are going to reflect the fact that hookworms infect the small intestine. So mainly GIT things like diarrhea, nausea, abdominal pain. Also, it will lead to iron deficiency, and that's because when the hookworms hook onto the lining of your small intestine, it's going to cause bleeding. And it's actually one of the leading causes of anemia and iron deficiency in the world. And because of that iron deficiency, it can cause fatigue. And I'll talk about the last two symptoms when I go through the life cycle. In terms of diagnosis, again, microscopy of the stool, and then the treatment would be albendazole, which is an antihelminthic. So with the life cycle, the eggs are in feces, and if the feces in the soil or on the ground, that can spread to other people. So what will happen is the larvae will hatch in the soil or wherever it is. And then if someone happens to step on that area, the hatched larvae will bury through the feet, through the skin, and enter circulation. So that's why you get the itchy skin. That's just from them burrowing into your skin pretty much. And then now that they're in your circulation, they'll travel to your lungs, they'll get coughed up, and then you'll swallow them. So again, that's what's causing the coughing, is the fact that you're coughing up the larvae into your, to be swallowed. And then the larvae are going to travel into your small intestine. That's where they will grow and colonize. So filariasis, it's caused by 4 species of mosquitoes that I've put there. And this is an infection of your lymphatic system. And that's a really key point to remember, because most of the symptoms are related to your lymph nodes and your lymphatic system. So for the first year, before the larvae have matured, there's pretty much no symptoms. But after they've matured, you get a bunch of problems, mainly to do with your lymph nodes and the circulation in your lymphatic system. So you would get an enlargement of the lymph nodes. You can get eosinophilia, which, if you remember from a few weeks ago, eosinophils will help to combat parasitic infections specifically. And that's why they would increase in number. And then you will get a gradual impairment of the lymphatics, and you can get obstruction because you have a bunch of parasites obstructing the circulation. And then you would get lymphedema, which is just a lot of fluid buildup in a part of your body, so your legs, for example, and it would just lead to your to that part of your body, like your limbs swelling up a lot. And that usually occurs after many years of infection. In terms of diagnosis, you would do a midnight smear. So that just means that you're taking the smear at nighttime, because the microfilariae tend to circulate the lymphatic system at nighttime. And again, you can do some serology for the antigens or antibodies and PCR tests. And with the treatment, you would avoid mosquito bites, and you can take some prophylactic drugs. And the life cycle is there. I won't touch into it, but you can have a look. So with pinworms, they're caused by Enterobius vermicularis, and they are transmitted through ingesting or inhaling the eggs. And this is a very, very common parasitic infection in children. So it's an infection of your skin and your small intestines. And a very key feature is that children often experience persistent anal itching and discomfort, particularly at night. And that is because at nighttime, the females will migrate out to lay eggs. So in terms of diagnosing, you just take a bit of sellotape and you see if there are any eggs on it, and you might also see some worms in the feces. And then you would use mebendazole to treat it, which is another antihelmintic. Okay, then we have tapeworms. So symptoms of tapeworms are usually, they're not so bad. They're usually mild. They could even be asymptomatic. And you're usually only aware of it when you find segments of it in your feces. But sometimes it may cause anemia and malnutrition. There's 4 specific types that you can have a look at there. And then in terms of transmission, it's again just eating contaminated food that's undercooked, particularly raw meat. And flukes, which I think is the last one, there are several types of flukes. So they infect different parts of your body. The most important one is the ones that infect your blood, but there are also ones that infect your intestines, your liver, and your lungs. So the ones that infect your blood are called schistosomes, and they cause schistosomiasis. So this is an important one to remember, and it can lead to chronic inflammation. And I've just put down there 3 different parasites that are blood flukes. So in terms of diagnosing, again, microscopy of the stools, and you can even look at the urine for any eggs, and serology and antigen antibody testing, like most other things. And then in terms of the treatment, you would use praziquantel.
Okay, so I'm just going to be touching on some anti-infection drugs. So I'll start off with antibacterials. So antibiotics are a form of chemotherapy, and generally we use antibiotics in 3 different situations. So you've got your directed antibiotics, which is when you know the pathogen and you're targeting that one specific and known pathogen. This is when we prefer to be using antibiotics, because it's when we can use the narrowest spectrum drug possible and we can target the pathogen. Empirical antibiotics are used when we know that there is a pathogen, in the person, but we're not quite sure what the pathogen is. We just know that we need to get rid of it. So you use a broad spectrum antibiotic, and that's empirical usage. And then you've got your prophylactic antibiotic use. So you use this preventatively to prevent the growth of any pathogens. Often you'll use this preoperatively, or sometimes if you've got like an open fracture, you'll use prophylactic antibiotics to prevent any infections growing in the bone. So antibiotics can also be either bacteriostatic, which slows or stops the growth, or they can be bactericidal, which completely kills the bacteria. So in general, we say the ideal chemotherapeutic agent is one that will get to the site of the infection, so it will go to where it needs to be. It will destroy this organism or slow it down enough that it can be destroyed eventually. It stays at the target site for long enough to be effective, but it can also just be eliminated from the body, and this won't affect the host cells. So this kind of touches on the idea of selective toxicity. So you want the chemotherapeutic agent to be toxic to the pathogen, but not to the host cells. So that's what you're really always aiming to do when you're choosing antibiotics, which is important when I touch on all the different types of antibiotics later. So just a few terms to know. We've got our MIC, MBC, and MEC. So MIC is the minimum inhibitory concentration, and that's pretty much the minimum concentration at which bacteria stops growing. Anything below the MIC is not going to have any effect on the bacteria, so it's important to make sure that when you're prescribing an antibiotic that you're choosing something that is above the MIC at least, if you want a bacteriostatic antibiotic. And then you've got your MBC, so that's the minimum bactericidal concentration. So that is the minimum concentration at which you can kill the bacteria. So if you have a look on this graph here, you've got your MIC down below, you've got your MBC up above. So you've got your bacteriostatic above your MIC and your bactericidal above your MBC. And then MEC is just your minimum effective concentration. So in this case, that's above the minimum inhibitory concentration, because below that there's no effect. And something important to note, this isn't really related to MIC, MBC, and MEC, but the post-antibiotic effect is something that just needs to be kept in mind, because after you have a bacterial growth, the antibiotics often just continue to suppress bacterial growth in the body. So that's just something to keep in mind, the destruction of the normal flora and bacteria of the body. So we've got two different ways of dosing when we're using antibiotics. So we've got time dependent and concentration dependent. So this graph on the left is an example of time dependent. So time dependent is when you achieve your desired effect with the amount of time spent with the concentration above the minimum effective concentration. So if you have a look at this graph, you can see in each graph, you've got like your peaks and you've got about 60% of the time above the minimum effective concentration. And that's the goal of time-dependent concentration dosage. And then you've got concentration-dependent dosing, which is where if you increase the concentration, you increase the effect. So the goal of this type of regime is to maximize the concentration, but make sure that you're not increasing the concentration above any toxic levels. So they're just two different ways to, I guess, administer and plan the dosing of antibiotics to keep in mind. So time-dependent and concentration-dependent. So a very, very important thing to remember, I don't know if someone's touched on this in a PSPirates session before, but we've got our antimicrobial creed. This is super important. It's very high yield. Like a lot of exams will ask you, for example, which isn't a part of the AM creed, all those sorts of things. So the antimicrobial creed follows the acronym MIND-ME. So M stands for Microbiology Guides Therapy Where Possible. So pretty much you want to know the causative organism, and that's going to guide what drug you're going to use. I, indications are evidence-based. So you want the evidence. You want the examples of the pathogen that is causing this condition, so you know that you are using the correct antimicrobials. Narrower spectrum, you really want to just choose a drug that targets just that bacteria. You also want to make sure that the dosage is individualized and it's appropriate to the site and type of infection. So you're not just using a kind of one-size-fits-all approach. You need to make sure that you're changing the treatment regime based on what the pathogen is. You want to minimize the duration of therapy because prolonged exposure to antimicrobials can cause resistance, like Caroline was talking about before. And you also want to ensure oral therapy where clinically appropriate. So that is MIND-ME, your creed. So, in general, the bacteria and the antibiotic what we look for in targeting, we've got our cell wall synthesis, folate synthesis, nucleic acid synthesis, and protein synthesis. So they're the 4 main targets for antibiotics. And I'll kind of run through these quickly. I'm not going to go into too much depth about each antibiotic. The information's all there on the slide, so you can revise that in your own time. But I'll just start. So probably the go-to antibiotic, first line defense for most infections, is amoxicillin. So this is a beta-lactam, so it is a bactericidal antibiotic, and it works by inhibiting cell wall synthesis. It isn't good if you are allergic to penicillin. So you've got to be careful about allergies with this one, and it can also lead to superinfections because there are a lot of bacteria now which are resistant to amoxicillin. So you've got to keep that in mind as well. But it pretty much is a first line of defense for most infections, especially only gram-positive infections though. And a little side note is that it is administered with clavulanic acid, which helps to counteract resistant bacteria. So next up we've got cephalexin, which is another cell wall synthesis antibiotic. So that's also a beta-lactam, but it's a cephalosporin, and it's also bactericidal. So it's very similar in that it inhibits cell wall synthesis. You should not use this one with a patient who's allergic to penicillin either. And it's often used as a second line of defense. So you use it for penicillin-resistant bacteria because it isn't penicillin, but it can't be used. It's not penicillin, but it shares a lot of similar properties. So bacteria that are resistant to penicillin might not be resistant to cephalexin. So it's often used as a second line defense. Then you've got vancomycin, which is a glycopeptide. It's also bactericidal, so it will kill the bacteria, and it also targets the cell wall synthesis. However, an important adverse effect to note for vancomycin is red man syndrome. So pretty much vancomycin causes vasodilation, which can cause the patient to turn red. So that's an important buzzword, which you will hear about probably on your exams. It's also nephrotoxic and ototoxic, so it's toxic to your kidneys and your ears. Vancomycin is currently the last line of defense, so you really use it for those difficult pathogens to kill, so like MRSA and C. difficile, and it's used for gram-positive bacteria as well. But something really important to note is the red man syndrome. Okay, so then the next target is protein synthesis. So you've got doxycycline, and doxycycline is actually quite an interesting drug because it's used for bacteria, but it's also used for acne and malaria. So if you're traveling overseas, to Africa, for example, a lot of people will be on doxycycline prophylactically, so they don't get malaria. So that's just an interesting thing to note. So doxycycline actually inhibits protein synthesis. So it binds reversibly to the 30S subunit. It's not a bactericidal, so it doesn't kill the bacteria, but it stops the development of this bacteria. One important thing to note about doxycycline is it depletes your calcium stores, so it can lead to yellow teeth and photosensitivity as well. So a lot of people who go over to, for example, Africa or other countries where you need to take doxycycline before going, they actually get quite badly sunburnt because they're very sensitive to that sunlight. But it's a very broad spectrum drug and shouldn't be used in children less than 8 years old or pregnant women as well. Okay, another protein synthesis drug, you've got gentamicin. That's a bactericidal one. So it binds irreversibly to the 30S ribosomal subunit. It does have some adverse effects. It's nephrotoxic, so toxic to your kidneys, and ototoxic, so it's toxic to your ears. And you generally use this one with gram-negative bacteria. So the other ones that I've been covering before, they're generally used with gram-positive bacteria, but gentamicin is a gram-negative bacteria indication. Okay, and next we have erythromycin and clarithromycin. So these two antibiotics are macrolides, so they're also bacteriostatic. They bind reversibly to the 50S ribosomal subunit, and they just, again, inhibit protein synthesis. So one thing to note with these is they should not be given to somebody with a heart condition because they're actually cardiotoxic. So they can lead to severe arrhythmias in the heart and also damage to the liver. And one final protein synthesis drug is chloramphenicol. So this one also inhibits protein synthesis, binding reversibly to the 50S ribosomal subunit. An important thing to note about this one is grey baby syndrome. So pretty much your child will turn grey with chloramphenicol. So that's why you don't use them in children less than 2 years old or in pregnant women. So that's another kind of buzzword. If you hear grey baby syndrome, you think chloramphenicol. Okay, so next we've got nucleic acid synthesis. So you've got metronidazole to start off with. So this drug interacts with your DNA. So it pretty much makes your DNA unstable, which means that nucleic acid can't be synthesized anymore. An adverse effect is that it's got quite a metallic taste, and a way to remember that is metronidazole and metallic. And it can also interfere with alcohol metabolism. But it's also used for parasites, like Sayumi was covering before. So often used for Giardia because it can target gram-positive and negative bacteria and protozoa. So it's used for quite a wide range of organisms. Next, you've got ciprofloxacin, which is a fluoroquinolone. It's bactericidal, so it kills the bacteria. It works by inhibiting DNA gyrase, and it does have some adverse effects. So it causes cartilage or tendon damage, cartilage damage in children and tendon damage in the elderly people. And it's also phototoxicity again, so that sensitivity to light. But it is a very broad spectrum antibiotic. It can be used for gram-positive and negative infections, which is not very common. The final target for antibiotics is your folic acid synthesis. So you've got your sulfones and your sulfonamides, which are bacteriostatic. So they just aim to halt the progression of the bacteria. So they pretty much inhibit the changing of para-aminobenzoic acid to folate, but they're not very well tolerated. So they're not used very often because there are a lot of allergies to this drug. Then you've got trimethoprim and methotrexate, which inhibit the conversion of folate to your purines. And if you have a look just down here, you use these drugs for a lot of different pathogens. So you use trimethoprim for bacteria, pyrimethamine for parasite, and methotrexate for cancer. So they're the same principle on how they work, but the drug differs for different pathogens and different causative organisms or viruses. Okay, one final group of antibiotics are your tuberculosis antibiotics. So you've got 4 of those. You really only need to know the R and the I of the ripe in detail and just know that P and E exists pretty much. So R is rifampicin. So this is an antimicrobial. It's bactericidal, so it aims to kill the tuberculosis bacteria. So pretty much the way it does this, it inhibits RNA polymerase, and then that means that DNA transcription is unable to occur. But it is hepatotoxic. One important part about rifampicin is the red-orange secretions. So it kind of turns your urine, your saliva, any other secretions reddish. So a buzzword, this is another buzzword, just like vancomycin is your red man and chloramphenicol is your grey baby syndrome. You've really got rifampicin being red secretions. Your I in your tuberculosis antibiotics is isoniazid, and that is another antimicrobial, and it's also bactericidal. So if you have a look in this image here, you've got your mycolic acids, and pretty much this drug inhibits the synthesis of these mycolic acids and then means that the tuberculosis, like the mycobacterium, dies. So, but these are also quite hepatotoxic, so that's something to take into consideration. They're not great on the liver. And then finally, you've got pyranizumide and ethambutol. You don't really know the mechanisms of action for these ones. They can be hepatotoxic and they can lead to visual changes. But pretty much for tuberculosis, it's a very resistant drug. So we use combination therapy, hence the RIPE. So you use multiple drugs to ensure the elimination and the clearance of this virus. So even though you don't really know how the 2 P and E really work yet, you know that you need to use kind of these 4 to really combat tuberculosis. Okay, antivirals. Antivirals, unlike antibiotics, aren't broad spectrum. There are fewer targets for antibiotics. Sorry, that's supposed to say there are fewer targets than antibiotics because viruses pretty much attack the host cells and then use these against us. So you can't really target all the things in your own host cells like you can in bacterial cells. So antivirals are actually only virostatic. They can't be virucidal because to be virucidal, they'll have to kill the host cells. So they really rely on a strong host immune system as well. And resistance is a huge issue with antivirals because viruses can replicate and mutate very quickly. An important example being influenza. Okay, so this is just something you can read through in your own time, just the types of nucleic acids that you can have and the kind of types of viruses that form. But some latent viral infections that we really try to combat with our antivirals. We've got our herpes simplex virus. So type 1, you've got your oral cold sores, and type 2, you've got your genital sores. And this virus hides in your dorsal root ganglia and also in your salivary glands, and it can resurface at different points throughout your life when you're stressed, when your immune system's compromised, all those sorts of things. And then you've got your Epstein-Barr virus, which is known as glandular fever. This lives in your lymph tissue and in your saliva, also known as the kissing disease. That's another latent viral infection. You've got your varicella zoster virus, particularly the chickenpox, which then goes to shingles later. So that also lives in your dorsal root ganglia, but it reactivates later in life when you're immunocompromised. And then you've got HIV, and I'll talk a bit more about HIV later. So this is something you can also just review in your own time. You really don't need to know this in much depth, but these are just the mechanisms by which a virus can attach and replicate and all those sorts of things. So one type of antiviral is acyclovir, which is a nucleoside analog. So this pretty much inhibits the viral DNA synthesis, and it means that the chain, it incorporates itself into the viral DNA and means that the formation of a DNA chain is terminated. This is generally not too badly tolerated. It can lead to malaise, headaches, GI upsets, and it's really used for your herpes simplex virus, so your type 1 or 2, your oral cold sores, or also your varicella zoster, so once it represents as shingles. Next, you've got your neuraminidase inhibitors. So you've got oseltamivir, which is also known as Tamiflu. So that's kind of like the brand name that everyone knows it by. This one inhibits neuraminidase, and it can cause GI disturbance. So it's taken with foods usually, and this one is used with influenza. Okay. Next up, we've got our HIV antiretroviral therapy. So HIV actually can't be fully cured. So the aim is to restore the immune function, resolve the symptoms, and improve the quality of life, reduce mortality and transmission, and also achieve maximum suppression of viral load. So this is pretty much monitored through your CD4+ count and viral load. So while someone who has HIV will have their CD4 cell counts monitored regularly to check if they are able to, if the immune function is being restored. Sorry, I'm just going to talk to my dogs. Give me 1 second. Sorry about that. So pretty much, to determine the treatment for HIV, we use combination therapy. So the aim is to have at least 3 different drugs from 2 different classes, and this is to kind of combat HIV and be able to reduce the viral load as much as possible. You kind of attack it from all sides. It's very difficult to ensure compliance for this. So often these 3 drugs are put into the 1 pill, and that can increase the compliance. But there are a lot of adverse effects to antiretroviral therapy, which can also decrease compliance. Okay, so this is an example of a whole bunch of different HIV drugs. You don't need to know this again, just something for you to have a look at. So you've got your protease inhibitor, which is known as ritonavir, and this inhibits late protein synthesis and processing, and it leads to the reduction of dosing frequency at the end. So you won't have to dose as much because it boosts the levels of other protease inhibitors which are naturally existing. An adverse effect is that it's hepatotoxic. It can cause GI upset, taste perversion, anorexia, headache, dizziness. There are a lot of adverse effects, as you can see. And there are actually a lot of potent drug interactions with this. Most notably, we've been with the CYP450 enzyme. So combination antiretroviral drugs, you also have tenofovir, which is an NITI, and it blocks reverse transcriptase, which pretty much prevents the transcription of HIV. But again, it's got some severe adverse effects, including nephrotoxicity. But this is also used as part of the combination treatment for HIV. And then you've also got zidofudine, which is an NRTI, but that's used to prevent the vertical transmission from mother to child. So this is an important one to know. So it pretty much prevents the HIV from being transmitted from mother to child. Okay. Antifungals, I'll whiz through this quickly, but pretty much to start antifungal treatment, you need a systemic infection. So there's not a whole bunch of antifungal drugs that actually exist at the moment. But antifungal drugs at the moment do target two unique structures. So you've got your ergosterol and your different proteins in the cell wall. Okay, so one type is your azole antifungal, which is an example is fluconazole. So this inhibits cytochrome P450, and it messes with cell membrane synthesis. So it's generally pretty well tolerated, but it can cause a bit of GI disturbance. This one is the most, this is your first line because it is so well tolerated. So you use it for broad spectrum infections, for example, like tinea, thrush, but you can also use it for candida, dermatophytes, and cryptococcus. So you've got a lot of things you can use this one for, which is why it's a really good go-to. So it's often a first line of defense for your antifungals. Next up, we've got amphotericin B, which is a polyene antifungal, and this binds to the ergosterol in the cell membrane, and it leads to cell death. But it does have a lot more adverse effects than the previous one. So it's got nephrotoxicity. It's also got fevers, chills, and vomiting. But it is the drug of choice for candida and aspergillus. So those are some more resistant and more severe kind of fungals. So you use it for the more resistant fungal infections. And finally, we've got caspofungin, which inhibits, it kind of disrupts the fungal cell wall. It doesn't have as many adverse effects, just got fever and flushes, and you use this one with aspergillosis. Okay, so I know that was a lot of kind of information dump for all of you to take in. There are a lot of antibacterials, antifungals, antivirals to take in. So at the moment, if you just kind of listen, that's good enough. I've got them all on the slides, all the information's on the slides, so you can read through that in your own time during swap back. Okay, so thanks for coming. Tune in next week. Meg will be taking you through the final lecture.